This is part of our FACE department seminar series. So the FACE department is the latest new clinical department in the Faculty of Health Sciences at the University of Cape Town. And we are an exciting combination of family medicine, emergency medicine, sports and exercise medicine, palliative care medicine, and primary health care. And the FACE stands for Department of Family, Community and Emergency Care. And today it's the division of family medicine's turn to present in the seminar series, and we're delighted to have Associate Professor Mosedi Namane with us today. So I can just basically give a short bio, but wanted to do credit to her background and experience. Prof Namane has been a joint appointee in our division of family medicine and the Western Cape Department of Health and Wellness for quite some time. And she has been a mentor, a leader in terms of clinical governance, but also clinical scholarship, which I think is a beautiful addition to both our division and our department. And I mean, we know her through her work at provincial level, especially in terms of clinical governance around pharmaceutical treatment and medicines use evaluations, and for which she has received several awards so far, and also has been recognized by the provincial head of health to be appointed at the provincial level to the pharmaceutical treatment committee that governs the use of medicines across the whole province. At substructure level, she's also the chairperson of the Southern Western Substructure PTC. And for this and all her work so far, she has been awarded previously in 2018 the Premier's Best Frontline Public Service Employee Award. We know of a special interest in community and primary care rheumatology, on which she's written quite extensively in chapters in family medicine and nursing textbooks. But today we're going to learn more about her experience as a Lancet Commissioner for Osteoarthritis in primary care. And as alluded before, she does consider herself as a clinician researcher, especially as she's not only does she have a postgraduate qualification in family medicine, but she also has a MSc in clinical epidemiology. I would welcome you to look at her Google Scholar profile and her research outputs over the many years. So Seri, it's really a privilege to welcome you, and thank you very much for preparing your talk today. We look forward to your presentation, and I'll be monitoring the chat for any questions, and I'm sure there will be time afterwards for some Q&A. So please, over to you.
Okay, thank you, Klaus. Yes, colleagues, I'm going to be sharing with you a story of my journey, okay, as a Lancet Commissioner. Liz will know, when I was first asked by the Lancet people to join them, I was so anxious. And I said, I don't even know what's a commission. And Liz had to explain it to me, okay? So 3 years down the line, when we are concluding our work now, so I feel like I should narrate the journey and to you. So the overview, I'm going to be talking about, to me, what is the business of the commission? What is the status of OA management at present? What could the management be like in future? So those are the things that kind of were questions that were answered along the way. And okay. I am not going to be sharing references and specifics, because there's still confidentiality. The report is not yet published, and we are writing up at the moment. I'm just explaining to you, in generic terms, what has transpired, what is, my experience in this journey of being a Lancet Commissioner of Osteoarthritis. So the purpose of the commission, from early on, I got to understand that it was to move away from the present poor health spiral that is associated with OA management. We do know that osteoarthritis is the commonest arthritis that's existing. It's increasing, it's burdensome because it causes disabilities and causes a lot of morbidity and mortality as well. And then about the commission, there was equitable representation from different regions in the world. There multi-sectoral involvement, interprofessional people who are there. I got to understand that the people identified had been sought out. It's kind of like a snowball sampling. They get to, and that we want, like, they explain to people that, can you please help us find someone who has got these skills and that skills. And for me, I was approached because they approached Stellenbosch to say, we want someone who works at, in clinics and is a primary healthcare practitioner and has got an interest in rheumatology. So that's how I was referred to them, because Stellenbosch identified me as such a person. And then, I had meetings with them. And then they also like the fact that I understand how to read science, how to appraise articles. My qualification in clinical epidemiology helped. The other thing that helped was because I've written on community rheumatology in the medical textbooks and nursing textbooks. I'm co-authors also of some articles that have been published in community rheumatology. So the first thing that the commission did was to make us understand the mandate of the commission. Some of us, like myself, I requested a one-on-one consultation for someone to explain things to me outside of a bigger meeting. They distributed and discussed examples of commission reports that were released recently so that we can have a feel of what kind of a report we want to produce in the end. The whole theme is around transformative, doable, evidence-based actions. New things that are evidence-based that can be implemented, and to move away from low-value care. And then the last thing that we did to address this mandate was to co-author a position paper that was published in the Lancet. Then the team sat down and started planning over several meetings to map the processes and the outcomes of what we desired. Now you'll see everybody now was given, we divided in groups. Sometimes you are given an assignment by yourself because of your expertise and so forth. So one of the first assignments that I had to do was on this topic, reflections on osteoarthritis and why the need for an OA commission now. Okay, where do we want to be in 5 years and in 10 years? And also come up with bold key messages to clinicians and policymakers. And this was from my own perspective as a family physician who's working at primary level. Okay. So also in our discussion, you could see that the playing fields within and between different countries were not equal. So this was important because the report that we were going to ultimately produce had to be user-friendly for all the regions and be implementable as far as possible to all the regions. So we had to try also to bridge a gap when we are writing. So earlier on, I was requested also to join three other colleagues coming from the LMICs and present on what are the barriers to have OA management programs in our regions. The OA management programs, I found out that, I mean, that was the first time that I got to know about that term or that program. It is almost like the baseline that you should have. If you've got osteoarthritis, patients with osteoarthritis, when you are thinking of providing decent care, the baseline is that should be something that must be in place before you even think about anything. So my understanding of this program is like a community-oriented primary care of osteoarthritis, like treating or managing this condition within the community. So that's what the OA management programs entail. And from our presentation at that ORC Congress, we published a paper. Subsequent to that, we had several rounds of meetings, and in between spaces, we were meeting one-to-one and sending stuff. In the end, we ended up having setting up goals. Our goals of what we wanted to achieve. It's almost like we themed all the things that we wanted to do and themed them into goals. And the group members were allocated to work on certain goals based on their expertise. So there was shuffling of you working with this group now, and then next time you're going to be working with this group because of this certain outcome that you want to achieve. And in the meantime, as I said, there were times when some of the questions that came up needed to be explored further. And once answers were got, because the whole thing is done systematically. So when you explore a question, it can be literature review or a little bit of piloting, whatever you are doing. And then because it's systematic, you are able to produce a paper and publish it during the process. I was also, I participated in a Delphi project for other members. They were asking another question. So that's the richness of the milieu of working in a Lancet commission. So now, how far is the process? We are now editing. Now it's 3 years down the line because the commission started in 2020, and we are aiming to publish our report by the end of this year or early next year. So we've achieved, we are on course for a 3-year journey. So we are at the process where we are editing and editing the collated document. And this document is released now and again for us to refine it. And oftentimes there's always, every time it's released, we are informed of how we need to edit it. So there's maintenance of systemic thinking, and this is often anchored by the bold statements that we fashioned along the way that are related to the aspiration of OA care in the future. We've now whittled down the goals to 4, and just an example is that our goal 1, it's around actually being able to classify patients, because osteoarthritis is not one condition, it's heterogeneous. So we should actually be at the outset knowing what sort of this patient has got OA based on the genotype or phenotype or biomarkers or so forth. Yeah. And then along the way, there are also people who've got IT skills. They're producing smart infograms that are able to capture things that you could, like 3 pages in one infogram. Okay. So that makes our report to be much more innovative and nice to read, easier to read. Then also the other thing is that the language that you use every time you're writing, you must be thinking, it should be patient-centeredness, there should be high-value care, we should be talking of lifestyle measures and nothing like non-pharmacological. Okay? And we don't speak of allied health. And when there is a palliative care measure, we don't include, we say this is palliative, this falls under palliative care. Okay? So everything must just be crisp and transformative. So now, coming to my perspective of OA management at primary level. Okay. So with all this knowledge and experience, I feel this is just a dream. So I'm asking myself, how can South Africa kickstart a comprehensive OA management towards 2030, where we say by that time we'll have achieved universal health care? So, okay, I am saying the rheumatology bodies should resuscitate the discussions that they had with the policy makers during 2010 to 2020. That was the bone and joint decade. In my readings, I saw that they had undertaken to do that, so that to integrate musculoskeletal conditions in care, to fight for musculoskeletal conditions to be integrated in the care of any patient. So I'm feeling that those discussions should be resuscitated, because then they will be able to influence policy. And then the other thing is dissemination and implementation of published OA management care programs. In my researching and whatever, I found out that actually there are physiotherapists from UCT and Stellenbosch who collaborated and produced an OA management care program for South Africa, but that has never been implemented. So that is what I would like us to use. We already have got it in South Africa, and that is what I included in the report. Yeah. Okay. Then the other thing is to establish a clinical service governance forum for care of musculoskeletal conditions. In the Western Cape, I have seen where there is proper clinical governance of something, of anything, then there is a forum for that condition, like the mouse meeting, which is a body where the nurse, midwives, the obstetricians and pediatricians and whatever, across all levels of care, sit together and they plan about who is doing what, who needs what. And everybody, if the MOU with Vanguard hasn't got a certain equipment, someone from Groteske here can assist to motivate for that equipment to be procured. So we need something like that for musculoskeletal conditions. If we are going to be able to implement future care, that is in the report that is going to come out. Then the next thing is higher institutions of learning, higher institutions of education must include an integrated teaching and learning thing. In South Africa, especially in Joburg, okay, from my readings, I found out that there is something called a CRFA. It's a program where they train, that is providing that thing. CRFA stands for Common Risk Factor Management or something like that. Yeah. So what they do is they train people how to provide integrated care or provide integrated health promotion or provide anything that is what they are doing should be in an integrated way. So vets can assist us, you know, to train our people to be able to meet what is required in the coming report, because that report is advocating for integrated care, because without that, this thing of silo, it doesn't work. So then the other thing is that my reflections on how I see OA management at primary level in future, okay, like by 2030, if we are going to be taking the report and using it as kind of like our Bible for managing osteoarthritis. Firstly, we have to understand that osteoarthritis is a whole joint disease. It's not what we've been taught that it's a disease affecting cartilage. No, it affects any structure around the joint. That is not a silent disease, that it contributes both to morbidity and mortality. Pain that is not controlled leads to sooner death. Okay. So that should be understood. The better differentiation of types of OA, I've already spoken to that. Prevention strategies like, for instance, biomarkers, those perhaps for research should go further in identifying biomarkers to be able to diagnose people early. But some of the prevention strategies are related to policy of the government to reduce trauma. There's a lot of osteoarthritis that is secondary to trauma. I saw on TV that the Minister of Transport was talking about something called Operation Vala Zonke. It means close everything. Okay, it's to vala the potholes throughout the whole of South Africa. There's a lot of trauma that has resulted from those potholes, accidents and everything. So those strategies like that, so it must be from all angles. The next thing is our management should include ways of stopping disease in its tracks. So once the disease is there, okay, can we use evidence-based maneuvers that tell us how to retard or stop the disease progression? express. There's a lot on nutrition, okay, that you will see in the report that addresses that. Integration of management of non-communicable diseases. Okay, that is very important because the report will make us to appreciate that inflammation is actually a common thread amongst non-communicable diseases. If someone has got OA and diabetes, for instance, you will never be able to control that pain if you don't manage diabetes, because diabetes comes with its own inflammation. So anything that has got inflammation in it, you treat diabetes correctly, then the patient will experience less pain, or the pain will go away completely. The other thing is inclusion of palliative care in management of OA, particularly in patients who have got what you call accelerated OA that behaves almost like an inflammatory arthritis and destroys joints and whatever. Some of those patients have got comorbidities that will not allow them to undergo surgical corrections. So there's a role of palliative care for such patients to make their lives much better. Okay. Then the next thing would be teaching and research. That includes dissemination and implementation of science. So now coming to advantages for being a commissioner for me, it's like I found it to be a training ground for thinking and writing systematically. I've got a richer understanding of the epidemiology of OA in Africa and the resources that we have and that we do not have in my region. I was surprised by the resources of South Africa. We've actually got ingredients to put a decent program in place if we can organize ourselves from start, things that are already in existence, but they're all over the show. So we just need to put things together. Okay, and then the next thing is establishment of international connections and also being invited for CPD meetings from rheumatology, which helps. And then publications whilst doing the work. That's a nice to have thing. So in conclusion, okay, the OA Commission report that is coming is a transformative blueprint for OA care. And just to repeat, South Africa has the ingredients to implement. However, South Africa needs a policy directive and leadership to do so by 2030. Thank you.
Thank you very much, Steri.
Are there any comments?
Any comments or questions? I'm just monitoring the chat. Yes, Liz, your hand up. Please go ahead.
Mosedi, thank you for that excellent presentation and congratulations on being one of the commissioners for this OA Commission. There are a couple of comments that I'd like to make. One was this business of being a sole representative for the whole continent. I find so many global things like throw in Africa or Asia and one person is representing this multitude of people. Yes. So one of my questions is how do you get kind of consensus? Do you canvass other people? How do you manage that was my one question. The other was just a comment on how frustrating it is that there is an OA management plan that's not being implemented. It's this issue of implementation. But another observation when you were talking about the palliative care for OA and the comorbidities, I must say that managing osteoarthritic pain is a lot more challenging than something like managing cancer pain, which is really quite simple and straightforward, but is so important for quality of life. So those were my 3 comments. Is 1, how do you represent the whole continent? Number 2 is, how do you overcome those frustrations of having the management plan but not having it implemented? And then this issue of integrating palliative care.
Yes, yeah. You know, Liz, as I told you, I mean, I knew nothing about this thing, you know, about the commission, what it was and whatever. So I only realized quite when we were already, you know, down the line that we actually need more representation from different areas. I know that they said it's much easier to work with people who are, you know, selected, and then they also provide you, you know, with a recipe of how to go about. And then this thing of chopping and changing, I actually quite enjoyed working with people who are coming from India and Brazil and whatever. So yeah, it's not ideal, but I think for starters, it's something. Okay, let me just say that. Yeah, we were a total of, we started being 23, but we ended up being 28 because along the way, there were other people that were being identified as being necessary to join us, depending on the questions that were coming, like health economics expertise that was required for something. So they found someone and whatever. But the long and short of, to answer you, that is not sufficient. You need more representation. You know, even if they said 5 people from Africa, 5 people from here.
Yeah. Siri, won't you switch your presentation off so we can see all of you when you're speaking?
Okay. Okay, yes. Okay, you can see me, né?
Yeah, thank you.
Okay, sure. Yeah.
Thank you. Those are such great questions, Liz.
Yeah. Yes, and then Liz.
What are your
but can I just follow up on the thing of the OA program? You know, I was amazed that we've got a homegrown OA management program that is superb. That was just hidden in the literature somewhere. And so what I did, we've got students who are doing pharmacy who come to Vanguard. So I think, you know, with pharmacy, they are also doing this integrated care. They are not only looking at medicines, you know, they do how to counsel patients around lifestyle things and whatever. So they needed to do a project. So we used that OA management program on them. I introduced it with to the students. So that program is running at Vanguard a little bit I just wanted to test out what it means, and then I realized that it's actually COPC. That's when, for me, it translated into COPC for osteoarthritis.
Sorry, Liz, I think it's on your end that
sorry, I didn't mute.
no worries. But I think, Sadie, I mean, I'm also looking at the attendees and I think especially what you're now is talking about, alluding to, is the multidisciplinary and interprofessional aspects of managing osteoarthritis in primary care. And I'm also seeing colleagues who are from the sports and exercise medicine community and other related disciplines. I was just wondering again, what were you thinking about how your work in this commission could also help shape both the practice and the teaching around managing osteoarthritis in primary care. And I like also the palliative lens that you've brought into this in terms of optimal symptom management and pain management, comprehensive care.
Yes, Klaus, I think even myself included, like I was not so aware that there is a lot that you can do. This thing of inflammation being the center of everything. Only I got to understand what it means now, because that's not in our teaching, that's not in our standard treatment guidelines, that's not in, so people don't know better, and it's almost like you won't die from osteoarthritis, just give you pain tablets and you go home. That's not sufficient. Okay? You can do a whole lot to modify the, how the patient, and you can tackle that from all angles. You optimize care for everything. You sort that also sorts out the pain that is related to osteoarthritis. I mean, the notion of osteoarthritis also, it's no longer exists in my brain. Okay, okay. There's always a little bit of inflammation that is, hence why people get pain sometimes, and more pain than other times. Then, then the other thing was tackling obesity. Like with other people, we've always been thinking it's a mechanical problem. Like if you've got too much weight, then there's too much burden on your joints and whatever, you're putting your joints under stress and whatever. It's more than that. Actually, if you look, there was some systematic reviews from the nutrition people that showed that people who are obese and who've got pain, oftentimes it's because things like your vitamin D and whatever gets deposited into the fat, and you need that is required for the integrity of the muscles around the joints, so I mean, those things are things that enthuse me, because I'm in clinical practice, and the more I discovered about things like those, it's just kind of like it's always aha moments and aha moments. So that for me was a rewarding. So it's more than just weight. There's a lot that happens. That fat is not good. And then the other thing is that people who are obese have got inflammation on their own. So that also, and that is why when you see people who are massively obese, some of them may not even be having minor joint problems, but they're aching everywhere. So that's the inflammation that comes with it. Yeah. So it's just,
and that speaks also to Liz's comment or remark about how there's this need for this patient-centered and holistic care. So to address all the issues that person living with osteoarthritis. I see two hands have popped up. The first, I believe, was Roland, and then Ishak. So maybe Roland, you want to go first?
Hi, can you guys hear me?
Clearly, thank you.
Thanks for a very informative presentation. When Klaus actually sent out this invitation, I was sitting in a meeting that was at 3 o'clock, and I thought, well, I must log in, because I do see quite a large population with osteoarthritis in the Mitchells Plain area. And me being a family physician there now with interest in sports medicine and actually completing my MPhil very soon in sports and exercise medicine, which has actually opened my world up on osteoarthritis even more. I can tell you the perception at primary healthcare level is most of my clients that comes and see me for the first time come with the idea that they need a steroid injection for their osteoarthritis. And they've never been counseled or educated with regards to what is osteoarthritis. And you've listed quite a lot of the risk factors involved. And I can tell you most of my clients do have those risk factors. And I see an elderly population, the majority of whom I see is above the age of 60, some of them in their 80s, but still well functioning. And we know in first world countries, the treatment go as far as stem cells. And I know from my sports science colleagues in private, they can give treatment up to hyaluronic acid for grade 1 and grade 2 osteoarthritis, whereas I've at least upgraded in terms of treatment. I can offer them PRP because simply I've got the equipment to do that. And I've just expanded a bit my skills as well in terms of that. And what I've also found is just to adjust your form of medication modality, and something that works well specifically for our osteoarthritic clients. I know we want to stay away from NSAIDs, but even our Voltaren suppositories, we don't have it at facility, but some of them, I've started offering them that, and those that can afford it actually go and they buy it. But the other thing for me as well with my clients is that I think something that we must bring more and more into specifically primary healthcare is the notion and the concept of exercise as part of your prescription. We've known there's many published research that has shown the benefits of exercise in management of chronic disease, hypertensive, diabetic, something that I'm starting to introduce as part of my practice at Mitchell's Plain CHC. And something that, if you look at the healthcare structure that we have, our physios are overworked, overbooked. We should invest some of our resources into I wouldn't say a rehabilitative program, but it's actually an extension of our primary healthcare management plan, which is exercise prescription, as well as lifestyle counseling for all our chronic diseases. And in my head, and from what my experience has been, is that is the absolute key. But also something that's quite striking is that when we see clients with osteoarthritis, they are quite often very far progressed. There's still different things you can try in grade 1 and grade 2, but we often see a grade 3 and 4, and sometimes they're very close. If I look at the knee osteoarthritis, that by the time I see them, a lot of them are very close to being referred for a knee replacement, or some of them I do refer for a knee replacement. So yeah, there's a lot of mortality and morbidity involved, but we should find a way to pick these clients up early in the osteoarthritis, because that's where we can can make the most difference in terms of what we put forward for management plan. And we quite often see them way too late. But yeah, I've got an interest in it because I see a really big burden of those clients that specifically come for steroid injection, and then you need to take them to the counseling phase, and quite often they've not been told what this disease is all about. So yeah, just some input from my side. Thank you.
Okay, thank you, Roland. Yes, I agree. That thing that common risk factor approach that Vets University is teaching even community care workers, it will help us, because if you counsel properly just for your hypertension or whatever, you're also managing the osteoarthritis without being aware of it. So I agree with you. Exercise, no smoking, eating healthily, shed the weight, all those things. Yeah, there's a lot of evidence to show that it helps to lessen the pain. There's less inflammation.
And that I know is now introducing a topic that I'm very sure Ishak wants to talk about, or maybe I don't want to preempt you, Ishak. Maybe
yes.
Your question is as a different angle. Please go ahead.
No, thank you so much. You know, it's fascinating, really. Mosedi, congratulations. I think this is really a brilliant endeavor, and you know, I'm really excited to kind of, you know, hear your updates on osteoarthritis and all the different kind of pathways and stuff. I mean, I think this is something that I definitely need an update on, and maybe something to think about might be a MOOC or something like that. You know, that might be one way to create in which information can be easily accessible for everyone. So that's the one suggestion. The other suggestion is well, first of all, I'm also quite excited that there's a lot of kind of prevention, health promotion kind of thinking that's going into the document. So that is very exciting. I think that and also kind of the role of exercise and how you know, it just kind of all ties together. Hey,
yeah, everything ties together.
Exercise, you know, reduces inflammation, to lose weight, and you know, it helps with all the other kind of risk factors for non-communicable diseases. It's a kind of if I could be you know, you don't get this one fix pills quite often, but exercise is one of those. You know, if we could put exercise as a pill, it would be a cure-all for many things. But that is something. And so just on the note of exercise, you know, there is this, we've got this fantastic new student organization called Medicine in Motion, or MedMo, and they are organizing walks or runs every Monday afternoon at 5 o'clock, which is open to everybody. So it's just kind of a bit of a spur from their side for us, because I think as a university community, I think we probably have a high prevalence of OA and NCDs. But yeah, I think that there's really some very interesting stuff coming from the work you're doing, Sidi.
Okay, thank you. Yes. Okay.
That's a great. Is it Medicine in Motion? That was us. Maybe you can put the link in the chat if you don't mind, Ishak.
Yeah, I'll do that.
Yeah, that would be great. Good to know about this initiative
Medicine in
among
Motion.
students. Is it? Because I find is it Medicine in Motion? They're based in the States, but they've got regional chapters, including South Africa. Is
yeah,
that
so
the same one that I'm looking at?
I think it's the same. It's the same one. It's so our students, our health science students, have actually taken the initiative and joined them. So they formed a UCT chapter of Medicine in Motion. That's my understanding. But I'll post. They've actually got a kind of a WhatsApp group, like for the running. The kind of the running or the walking on a Monday afternoon. I'll post the link for that. I'm not sure if they've got. I must actually find from them if they have an actual, you know, the UCT chapter Medicine in Motion kind of WhatsApp group or Facebook group. I need to find out about that.
Wonderful. I mean, that's so encouraging to hear that students are leading the change.
Yes, and then the last thing that I didn't emphasize, but because I don't want to talk about it before the report is released, I'm not going to discuss the details around it. It's the low value care that is being offered everywhere. So it's in the report, but I don't want to discuss it now. I was just discussing things that are positive. We'll just wait for the report to come out first, yeah.
Do you have any idea when the report might be forthcoming?
This is our last. We are finishing. We are editing and editing and editing now. Yeah. So it will come out at the end of the year. It was a 3-year process. We started in 2020, so we are on time and on track. So yeah. So by the end of this year or the beginning of next year, it will come out. Yeah. No, I'm saying this because Roland was talking about, medicines that were given and the injections. So I don't want to talk about that yet, because there's a lot of low value care that has been, or even harmful care, but it will be reported in, but mostly in private or something. I don't know. And it's common, and unnecessary surgical procedures and whatever. Yeah. So those will appear in the.
That's a very nice sneak preview.
Yeah.
and a watch this space announcement. Yeah. I'm trying to see. I've popped in the chat, but I'm not sure if it's accessible to everyone. The announcement of the Lancet Commission of Osteoarthritis in 2020 and beyond, which was published in the Lancet, and the lead authors were David Hunter, Lynn March, and Mabel Chu. But it also lists Mosedi Namane as one of the list of commissioners. Sounds like you say, it was initially a smaller group, but it was also then a larger group.
No, that was just that one was a statement of what the work is going to be about. It was providing clarity of it's a report, the first report, just to say what the commission is about. Okay, so the real report is the one that I'm talking about now.
Yeah, that's the one that we're looking forward to.
Yes.
I mean I'm wondering if there are any more questions maybe from the colleagues on the call. It's really lovely to see the wide range of audience members, and this recording, this talk is being recorded, so it will be accessible to others later on. Maybe are there any last couple of questions? Ishak, is that a new or old one? Sorry, I may have missed it.
Yeah, so just another question came to mind. So I may have missed, you may have spoken about it before, Sedi, but in terms of kind of local collaborations with rheumatology and stuff, to what degree would that have potentially been part of the process of the commission?
There are lots of rheumatologists there, but it was just they didn't need more rheumatologists. They needed, like other people who are also involved in joint care on the commission. So yeah.
Okay. No, thanks, Sedi.
Yes. Yeah. There were lots of
But maybe go for it.
No, my thinking is, like in terms of strengthening the COPC model, and how can we look at ways in which I remember being at clinics where dermatologists would come and rheumatologists would come, to the primary level care as well, it's always interesting to get more input. And I'm just a thick question, and I'm just thinking out loud in terms of, with us as FACE and kind of, us being kind of, shall I say, a gateway body to a certain degree, and you know, ways in which we could potentially, this might be another way in which we could strengthen collaboration between different parts of the university or faculty as such.
Yes, yeah. Yes, in the metro, I'm aware that Northern Tygerberg substructure, they've got that collaboration between, you know, like between Tygerberg Hospital and the family physicians and the clinics and whatever. So they've already got something going. I know because even during the COVID times, you know, I would hear family physicians coming from there that we had discussions with this is how we should be looking after patients in the community who've got arthritis during COVID and so forth and so forth. So there's already something happening there, but it would be nice to be duplicated elsewhere. Then the other thing that I heard from them also was that they are getting regular training. Most of them now know how to inject joints, how to look after patients. You know, they've been trained how to safely look after patients on methotrexate, how to monitor for toxicity, how to do things and whatever. Yeah. So it would be nice if it can be duplicated everywhere else. That is why I was saying the mouse meeting, I like that because now it's not only an area, it's a thing for the whole metro, you know, it's not just for one place, it's everybody's involved in that. Yeah. So yeah, so that's the extent that I know about collaboration of, yeah, of rheumatologists with primary care in the Western
What
Cape.
is it? So what is it meeting? Sorry, Sadie.
It's called the mouse meeting. It's MOU, and I don't know, Katie is somewhere here. She can tell us what SE stands for. But yeah, but it's midwives with obstetricians and pediatricians and neonatologists and whatever. All of them meet, you know, like once. They also invite family physicians. I often go, and Katie's on the call here. She also attends that. Yeah. So it's lovely because it's everybody across levels of care. And it's almost like your business is my business because we see the same patient. So everything is refined. No one is confused about anything in obstetrics, at least in the metro. I don't know about elsewhere, but yeah, because you know exactly who to call, when, how, what to do. There's just, okay. I mean, I'm not a midwife, but I also know who to call for what and whatever. Because yeah, there's a lot of structure in that. So something like that would be very helpful. And maybe to be duplicated throughout the whole province. You know, like what the PPTC is doing, whatever they are doing, it's for the whole province. It's never is for one, you know, with representation from everywhere. So we need something like that. So we've got examples of things that are working. So it's, yeah, I think the culture in the Western Cape has been developed for something like that to can happen. Fertile ground, it's fertile ground. Okay.
Thank you so much. I unfortunately don't see Katie on the call anymore, but maybe that is, like you say, something that one can take forward as one of the dissemination strategies from the Lancet Commission work. So also, yeah, to reinvest locally the findings and learnings to strengthen this in terms of service strengthening. And like you say, maybe building on the existing models of integrated care and developing one for primary care osteoarthritis. Yeah.
Okay, thank you.
Colleagues, yeah, I see this is just 1 minute before 5. I think it's time to wrap up the conversation. I really want to thank you for joining today and for Prof Namane, Mosedi for making yourself available. to give us update. And we are really excited to look forward to that report that summarizes the work done over the last 3 years. And I remember at many times that you were saying it was a hard but rewarding work. And I think we are really proud of you for having been part of that commission and for representing us there. So yeah, thank you for putting in those hours and not only being locally relevant but of international relevance.
Yes.